The title for today is New Horizon Within Sight for Hemophilia. This is my disclosures. We live in exciting times, and I think we have had a long time in hemophilia that we did not have any treatment. And I honor only with a picture Judith Poole, because of course I have not enough room in my slide to honor all the people working so hard, and many of you are here in the audience, what we have reached today. In the 60s, when cryoprecipitate became available, we had for the first time some treatments, but it was of course very few. And then really difficult periods appear. And in the 80s, when we thought we had our next grail with concentrates, that the disastrous infection period for the hemophilia community appeared. Then the recombinant products were really highly welcomed, not only because they were safe, but also because we could have a more endless supply. So the opinion at our time was that we really could give prophylaxis to much more patients that before we just not had the opportunity to do so. But now we reach much higher skies. And I think we have to acknowledge today that from a model of shortage, we have to come to a model, we are coming to a model of plenty. But I hope you recognize the model of plenty picture that I took for today, because the story we have to choose carefully when we are in paradise. We know that. Because when we go in a surplus, then we can have problems that we have to choose which product is the most appropriate, or which combinations of products are the most appropriate for our patient to use. And what Alain Well yesterday also pointed out, very elaborate, is that we have still so much patients in the world that have no choice at all and really live in a period where there is no prophylaxis, no treatment, while we now reaching to cure, what of course is really exciting. Again, I think it's important to estimate that these are the data from the last WFH World Survey, that the median factor usage is 0.83. That's really very low. And I think it's even more interesting if you look in the interquartile range, because that means the range between 25% and 75%, that only 25% of the world population gets more than 4 units. And 4 units we in Europe have accepted in a couple of years ago, that this is the minimum that should be available in a country to give adequate treatment to patients. So there's still a long way to go. And this slide you have seen before, and I don't want to go too long into detail, but I think it's important to recognize that if you look in the population, that the majority of the population, 60% lives in the Asian Pacific area, and they use only 17% of the global use of factor VIII. And for Africa, where 17% of the population is living, they have 2%. So I think there's such a clear imbalance. That is something. And of course, that reflects very much the treatment options and what we can do today. What I also want to recognize, she has been also very inspiring for my own career, is Ingmarie Nielsen. Ingmarie Nielsen really looked to the phenotype of hemophilia at that time when they had first the opportunity to differentiate between the different severities. And she saw that patients with moderate hemophilia that in fact have just a few percentage of factor, what is still very strange, that just with 2 to 3% of factor level, they hardly bleed. So she took the opportunity as soon as some products became available in her country to start to use this first. And of course, she first started to use it in patients in their teens because they were really more in the hospital than outside the hospital, but so much bleeding. But over time, she recognized that it was far too late. She had less bleeding, but she still had a lot of arthropathy. Some other message, what can't be overestimated still to confirm, I think in our part of the world we have a little bit forgotten about it. That's the importance of home treatment. Because home treatment makes a patient independent. For me personally, I always find that every patient is his own hemophilia center. They should have their products at home. They should be able to treat themselves at home and feel that they are independent. And of course, they need a center when they need surgery, when they need backup, they need to have control. We need to collect data even more now than in the past. It's very important, but they need their independence. They should not have to travel when they have bleeding. Prophylaxis took a long time to be accepted. I don't know what's in the words that people thought that giving something what is not really needed, not for a bleed, it's not needed. Patients with hemophilia, severe hemophilia, they bleed. And they start to bleed very early. So if we want to prevent the sequelae of the disease, we have to start very early with any modality that we now can pick to prevent that from happening. If we want these patients to reach adulthood as normal adults, be active in society and go to schools. In the US, for reimbursement reasons, the prophylaxis was only accepted in 2007. That means that in the US, even in a country what can afford now very high dosing, that a lot of all the patients still have joint disease because they never started very early on prophylaxis. And the criteria for the start of prophylaxis now has been generally accepted in 2014, and more we'll see that this is really accepted, and really happy to see not only in our parts of the world, but also in the developing countries. Again, the slides that you have seen before, but can't be overestimated, the importance. You have to start very, very early. And we have had a lot of debate in the past about a milder clinical phenotype in severe hemophilia. Severe hemophilia doesn't have a milder clinical phenotype. They all bleed. If they don't bleed, please go back to your lab and confirm your diagnosis. So looking in the effect of starting prophylaxis, so at the left side is the picture of the Swedish population. At the right side, the Dutch Van Creveld data, where they also could confirm that only ones that were started very early on prophylaxis are really get hardly, and of course we still have to wait for data until they're 40 and 50, but we expect that they're doing very well. But do we really implement prophylaxis that early? So this is an interesting article that I can advise you to read again. It's published in Hematological in 2015. We looked in the data we had in our collaborative work in PetNet about different periods. And in the blue, and you see the number of patients that were in that, so all pups. So in the 1990s, you see 138, and then going up, because especially after we started the PetNet registry in 2000, we have much larger numbers, so we have 300 patients. So we looked how many of these patients really started prophylaxis before they had joint bleeds. And in red, you see 0 joint bleeds. You see that this is still a challenge to get. 1 joint bleed, something that we would like to achieve, is going better. But if we look over time, we see gradually that we do better. We see less patients that have already 2 joint bleed before we start prophylaxis. And for me, start of prophylaxis is a treatment regimen and it should be implemented. So you have to measure what you're doing if you later on want to measure the effect of your outcome. So in general, the individualized treatment to improve outcome, I think in general we can accept for very small children that we have to start early, and since we should start after the first joint bleed. When they're becoming more older and more active, they probably have a higher bleeding risk. There's a huge variation in T-half, and it's very important that we do much more pharmacokinetics to take full advantage of all the new regimens and extended half-life products that we have now available. For the more older patients, there we really need a careful consideration by the hematologist together with the patient, and of course, what he wants to get in his life. It's very much depending on his joint status and individual activity. Is it safe to reduce factor VIII prophylaxis frequency in children? Again, maybe because I'm here already a long time, of course, we understand the burden of infusion of children. But to reduce frequency from 3 times per week to twice a week, but at the same time have again 3 days a week that the child is not, or 2 days a week, that the child is not effectively protected and really still can have bleeding, I think that's something that we have to wait very careful whether that's worthwhile. And it's very important to talk with the parents about it. We need pharmacokinetic in it. The half-life of children is much shorter. So if we want to go to less frequent infusion, we might really have a risk of bleeding. And I think in general, especially in children that have not clear activities, they are active if they are normal whole day, they should have a higher trough level. So they are much better protected and don't have to think every time, or the parents, that they are nervous when the child does any effective, and that they have to come to the hospital when something happened to the child. So you can read this article. I saw a recent one again in Hemophilia about this too, but I think, again, collect data, be careful, do PKs, and see if it's really feasible and safe to reduce the frequency in children. For hemophilia B, of course, it looks much more better. And we have seen already in this meeting several presentations on the different factor IX product, and they are all very effective. They all really have increased the half-life into that once a week, and probably in some patients even until 14 days, if a low dose of 25 units gives protection to 2.5%. But what also is important, the data that we get from the companies at the moment the product is marketed, and Alfonso Lloria is spearheading this project international, this data are based on a small group of individuals. And of course, it's always easier to read the mean and look for the 40–50%. But there's a huge variability in between the different, not so much the different products, but in the products themselves. That means that you have to adjust this to your own patients and to really see what the effect is of your patients, and look to the data and have your patient involved and develop a schedule. What's the best for him in the circumstances that he is living and the activities he is performing. Now we come in an area where we are rebalancing hemostasis. That means it's not that we take advantage of hemophilia being a monogenetic disease where we know that there's a limitation of factor VIII or factor IX, or of course one of the other rare diseases where we just infuse a little bit protein and that's it. No, we are now going to work with the whole scheme of hemostasis, what's a very complicated one, and not only complicated, it has a high inter-patient variability. That means that we have really to be careful when we going there in different patients. So broad knowledge of hematologists is needed with a good backup of coagulations laboratory to understand what might be the potential risk of new choices in individual patients with these new drugs, but also in the co-medications with bypassing agents of factor VIII. Because what we want to have, of course, is that we infuse or rebalance hemostasis in a way that we get an effective clot, but the balance can tip over very easily. And we have seen that we can get bleeding and thrombosis, what we have never seen before. That makes that we really have to be careful. We need to have very close collaboration in our field between academia, companies, and have the data of the patients collected and really address safety issues and issues on dosing. And a lot of the issues we currently are unknown. Please think about my first picture of paradise. Rebalancing hemostasis, we are doing it on several levels. We have the opportunity to look to the tissue factor pathway inhibitors, where we have an interesting new drug with still very little experience on. We are working with fitusiran, where there's already more data in public, and we have seen already some problems there, but of course they were farther advanced. And this is another options where we look in, so fitusiran looks in antithrombin 3 mechanism, and this is another approach where we approach protein S and see how we can work in, on that part of the mechanism. Just an overview, I took this from a recent publication in British Journal of Hematology, and of course a lot of publications have been coming out recently, and I think we are very much all excited about imicimab, what has been showing already a lot of good data. I don't going into details because you have heard so much about it. But I think it's really interesting that we have now a lot of data on once weekly subcutaneous dosing, and it seems even possible, and first results were demonstrated yesterday, that we can go to once every 4 weeks dosing. But of course, it's only suitable for hemophilia A, an inhibitor, and not for hemophilia B. We have seen, and that was I was pointing out, we have seen new side effects. Completely unexpected. While if you talk to more people in the fields, some already had some concern that something could happen. So we have to talk very careful to each other, and we have to be closely working with the patient community to educate them on the opportunities, but also on the risk, and what to do to limit the risk. Fitusiran, the siRNA against antithrombin, same subcutaneous dosing, and it can be used both for hemophilia A, B, and inhibitors. And so far, again, a fatal thrombosis, probably not so much because of the drug, but because of the combination with factor VIII. And we have still the adagium in hemophilia, both by the doctors and the patients, in case of doubt, treats. So maybe in this new era, we really have to reconsider some of these issues again. But we don't want to put them at risk of bleeding, so be careful. And then, of course, all the monoclonal antibodies, that one of them is here, and I'm sure next time this list and this table will be much larger. It's also subcutaneous delivery, and there are only early data in animal models, so I'm not going to tell too much about it, but it's exploding. Every day you have to almost to make new slides about the progress that's going on. A very important article was published by Peter Lenting last year in Blood, where and he will present tomorrow at this meeting, where he looked at the different mechanism between activated factor VIII, when it is activated in the normal way, what we do when we infuse factor VIII, and when it is stimulated by imicimab. And I have not the time to go to all the differences, and he will present that more in detail tomorrow. But I think for this audience, it's very important to understand that in normal hemostasis, factor VIII activity has a kind of on-off mechanism, what we quite clearly understand. And when it comes to imicimab, this is working the whole time. That's, of course, also the beauty of this drug. But we have to think differently when we are going to use these drugs. When I started my career in hemophilia, they said, what are you going to do in hemophilia? You know, everything is invented. They have factor VIII, they have safe products, they are recombinant, and they have gene therapy. It's almost there. Now, my career in hemophilia might end not too long from now, but it took a while. And I can really encourage you to read this very interesting overview by Dunbar and Katie High that has been published in Science, where they made an overview about the whole period and all the steps that were taken to really come now with safe therapy. And of course, there's still issues, and Glenn Pierce can very nicely explain about the unknown unknowns. Let's be optimistic, but let's be critical by all the steps we make together, because we have safe therapy. But I think it's exciting, and it's exciting what kind of achievements have been reached and how we are still learning to address and give a cure to the patients, because that would really be, I think, the dream of all of us. I had to choose, but it was not that difficult. I think these two articles that last year were published in the New England Journal, in the same journal, it's amazing how much articles the hemophilia field has now in the New England Journal. It seems to be becoming our new home journal. And of course, you have seen these data, but I think the exciting news is that both for hemophilia A and B, we have levels, sustainable levels in a normal area. And this is really something what, especially for hemophilia A, we thought I don't know how long this will take, but I think we all speculated, but we were completely unsure. But it's there, and it's there to stay. And we will see more products coming on, but it seems also to be these are still unknown unknowns, but there's a lot known, and it's a safe therapy. So again, something that's always dear to my heart is how are we going to measure the effect of gene therapy? And it seems that a lot of people still think that we have to measure EBR, because in the past, of course, hemophilia was characterized by bleeding, but we are beyond that part. And to the right, you see a picture, but that has been used a lot in many publications, but don't forget that our data from a single center have not been confirmed in other data. But exactly, we can point at the 15% that you need to reach, but I think it's important to recognize that after 3%, that there's hardly one bleed per year. That means when you want, as a regulator, to measure outcome, the effectiveness of outcome, your bleeding rate is not a very simple measure. If a patient gets a trauma, he will have a bleeding. Is that because the therapy is not effective? I think we have to do better, because we have now laboratories and we can measure factor levels. So for me, sustainable primary outcome for gene therapy is sustainable levels. And we had a workshop in Montreal where there was a kind of consensus about it, and I hope EMA is about to accept this, and I hope FDA is also going to accept that the primary outcome should be sustained factor levels over time. Did we do a lot? again, coming back to my first slides, I think these pictures you have seen, but I like it very much. It's first the Russian prince that always was standing there and also on the book, and this is a young boy in Africa. We have done nothing for a long, long time. We just let them alone, and we said, oh, episodic treatment if there was anything, but prophylaxis can do so much. And everyone was saying, for so long, prophylaxis is so expensive. But in our parts of the world, we went to very high dosing in patients that had already joint disease, while the very early experiments, and I couldn't resist to put it in again, a very small study, but very elegantly performed in the 60s by Professor Schimp in Germany. It did not get that much attention because it's in German. He already saw that only low-dose prophylaxis was effective when you gave it 3 times a week. If you did it only once a week, because of the half-life, patients still bleed. Twice a week was not effective, but 3 times a week, low dose did completely prevent bleeding. Now, I think the patients did not change. That message is still true. And it's so wonderful to see that low-dose prophylaxis in children that have not joint disease, because I think when you already have target joint, low-dose prophylaxis might not be sufficient enough. It's accepted, and it's accepted policy by the WFH. The humanitarian aid program is really a changer. In such a short time, and this is really because of everyone that's supporting this program. Of course, the companies that support this program, and I hope many more companies are going to follow. It's amazing that such a short time we were reached 60 countries. And 25% of the amount of the donation in the last year has been used for low-dose prophylaxis. And 12 countries now running prophylaxis program. And this is really, I want to congratulate all the doctors, nurses that believe in this and help us to make this true. Here, one of the centers reason you see the young boys that come in several times per week. And of course, if you start prophylaxis after a while, you also have to start home treatment and educate parents and let them have some files at home and infuse, because that will really reduce further the burden for them. We have now 1,500 children on low-dose prophylaxis. That's really amazing. In Pakistan, it's also now accepted. Several of the colleagues came to me a few days ago and informed me that they really have started. So thank you for doing that, because it's a lot of time and efforts that you have to take to get these children so early, so frequent in your clinic and infuse them. I know, coming from a country where we have done it already a long time ago. In India, there is also low-dose prophylaxis. And these are recent photos from a trip we had in India, where you see in the left still a recent picture of boys in their tens and tweens that really had no therapy before, with awful joints. And you start the picture of the crying child. He was in the clinic in Mumbai with 2 joint bleeds. And he is 9 months old. So they start to bleed very early. And here you see the acceptance of the families to start to infuse the children. And several of them are also now on home treatment. Of course, it's a schedule, they need education, but the way has been started and the way it should continue. And I want to thank everyone who is supporting the humanitarian aid program. I want to thank Asad Afar for the motivation he brings to the world. And I want to conclude that prophylactic treatment should be offered to all patients with severe hemophilia. Episodic treatment cannot prevent arthropathy. There is an explosion of new products for hemophilia, makes it possible further to individualize treatment and to lower the treatment burden. New 1 to 4 week subcutaneous agent will further facilitate treatment. But really in red, more knowledge on efficacy and safety is needed. Gene therapy is within reach and will deliver a cure in the near future for many more patients with hemophilia A and B, with sustainable levels for factor 8 and 9. But of course, there are still limitations about the accessibility. The AFA factors might have a problem, but I believe that we will overcome that and that more patients will get access to this very good and safe therapy. Of course, we also, I'm a pediatric hematologist, so the children are very dear to my heart. Please also consider the alternatives because the children would benefit the most from gene therapy. And new strategies with lentivirus and gene editing are underway. However, again, most patients are still undiagnosed. And why would you diagnose if you don't have treatment? And they die from bleeding. And low-dose prophylaxis for children will enable a new generation to reach adulthood with limited arthropathy, making them ideal candidates for gene therapy. Efforts from all stakeholders is required to ensure treatment for all. Thank you very much. I want to thank my family that's also is supporting. My husband went even to Ireland to taste the whiskey before I came. And thank you all.